Dissociative disorders represent a fascinating and complex group of psychological conditions characterized by disruptions or discontinuities in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. These disruptions can be sudden or gradual, transient or chronic, and may manifest in countless ways across different individuals and cultural contexts. At their core, dissociative disorders reflect the mind's remarkable capacity to compartmentalize experience, particularly overwhelming or traumatic experience, when integration would be psychologically devastating. While often misunderstood or viewed with skepticism in both professional and public domains, dissociative phenomena have been documented across cultures and throughout recorded history, suggesting they represent fundamental aspects of human psychological functioning rather than culturally bound or iatrogenic conditions. The modern conceptualization of dissociative disorders has evolved significantly over time, shaped by shifting paradigms in psychology, psychiatry, and neuroscience. Early descriptions emerged prominently in the late 19th century through the work of pioneers like Pierre Janet, who distinguished dissociation from repression and emphasized its role in traumatic stress. Interest waned during much of the 20th century as psychoanalytic and subsequently behavioral paradigms dominated psychological thought, but a resurgence began in the 1970s with renewed attention to traumatic stress and memory processes. The contemporary understanding of dissociative disorders integrates perspectives from attachment theory, developmental psychopathology, cognitive neuroscience, and traumatology, viewing them as complex adaptations that originate largely, though not exclusively, in response to overwhelming experiences, particularly those occurring in developmentally sensitive periods. According to current diagnostic systems, dissociative disorders include several distinct but related conditions. Dissociative Identity Disorder, DID, formerly known as multiple personality disorder, represents perhaps the most dramatic manifestation, characterized by the presence of two or more distinct personality states or experiential identities that recurrently take control of behavior. These identity states typically have unique names, characteristics, mannerisms, and self-conceptualizations, and may differ dramatically in their access to memories, emotional responses, sensory motor functioning, and behavioral control. Individuals with DID experience significant amnesia for everyday events and important personal information that cannot be explained by ordinary forgetting. The disorder is associated with significant functional impairment and often co-occurs with post-traumatic stress symptoms, depression, substance use disorders, and personality disorders, particularly those characterized by affective instability or impulsivity. Dissociative amnesia involves the inability to recall important autobiographical information, usually of a traumatic or stressful nature, that cannot be attributed to ordinary forgetting. The amnesia may be localized to specific events, selective for particular aspects of experience, generalized across the lifespan, or, in its most dramatic form, manifest as a fugue state where individuals physically travel away from their homes or work while assuming a new identity with amnesia for their previous identity. These fugue states, while rare, highlight the profound ways in which dissociative mechanisms can compartmentalize entire self-states, preserving psychological functioning in one realm while sequestering access to potentially overwhelming memories, emotions, or self-knowledge. Dissociative amnesia typically occurs in the context of overwhelming stress and often remits when individuals are removed from traumatic circumstances or provided appropriate psychological support, though recovery of memories may be gradual and incomplete. Depersonalization/derealization disorder involves persistent or recurrent experiences of unreality, detachment, or unfamiliarity regarding oneself, depersonalization, or one's surroundings, derealization. Individuals experiencing depersonalization might feel as if they are outside observers of their thoughts, feelings, sensations, or actions, perhaps watching themselves from a distance or feeling as if in a dream. Those experiencing derealization might perceive their surroundings as unreal, dreamlike, foggy, lifeless, or visually distorted. Crucially, reality testing remains intact. Individuals recognize that these perceptual alterations represent subjective experiences rather than external reality. Nevertheless, these experiences can be profoundly distressing and disorienting, significantly impacting quality of life and functionality. While transient depersonalization and derealization experiences are relatively common in the general population, particularly during periods of stress, extreme fatigue, or substance use, the disorder is diagnosed only when symptoms cause significant distress or functional impairment. Other specified dissociative disorder and unspecified dissociative disorder categories capture clinical presentations that don't fully meet criteria for the specific disorders described above. These include mixed dissociative presentations, identity disturbances due to prolonged and intense coercive persuasion, such as brainwashing or indoctrination while captive, dissociative trance states, and acute dissociative reactions to stressful events. In some cultural contexts, certain types of dissociative experiences may be normal parts of religious or cultural practices, such as possession trance states that occur within approved cultural or religious contexts. These normative experiences should be distinguished from pathological dissociation that causes distress or functional impairment outside culturally sanctioned contexts or beyond expected parameters. The etiology of dissociative disorders involves complex interactions between biological vulnerabilities, developmental experiences, and sociocultural factors. Traumatic experiences, particularly chronic interpersonal trauma occurring during childhood, represent the most consistently identified risk factor. Studies show that 80 to 90% of individuals with dissociative identity disorder report histories of severe childhood abuse or neglect, often beginning before age 5 and continuing for substantial periods. However, trauma alone cannot explain why some individuals develop dissociative disorders while others with similar experiences do not. Factors that may influence this differential vulnerability include inherited differences in stress reactivity, developmental timing of trauma exposure, presence or absence of supportive relationships that help integrate traumatic experiences, and sociocultural contexts that shape the meaning and expression of both traumatic experiences and dissociative responses. Treatment of dissociative disorders typically involves a phase-oriented approach that prioritizes safety and stabilization before addressing traumatic memories or identity integration. The initial phase focuses on establishing therapeutic alliance, reducing self-destructive behaviors, managing symptoms, and developing adaptive coping skills for emotional regulation. Skills training in mindfulness, grounding techniques, and affect modulation helps individuals manage dissociative episodes and stay connected to present reality. The middle phase involves carefully paced processing of traumatic material, helping integrate fragmented memories and associated emotions while maintaining psychological stability. For those with dissociative identity disorder, this phase includes improving communication and cooperation among identity states, gradually working towards shared awareness and functioning. The final phase focuses on consolidating gains, developing post-traumatic growth, and addressing developmental deficits or identity issues that extend beyond trauma processing. Psychotherapeutic approaches showing evidence of effectiveness include trauma-focused cognitive behavioral therapy, eye movement desensitization and reprocessing, EMDR, adapted for dissociative symptoms, sensoromotor psychotherapy addressing somatic aspects of trauma, and psychodynamic approaches that emphasize understanding the defensive functions of dissociation. Regardless of therapeutic orientation, effective treatment respects the adaptive origins of dissociative symptoms while helping individuals develop more flexible and integrated ways of managing overwhelming experiences. The therapeutic relationship itself serves as a crucial context for this work, offering a secure attachment that facilitates neural and psychological integration. Treatment typically extends over considerable time, reflecting the developmental nature of both the disorders and the recovery process. Pharmacological interventions play a limited but sometimes important adjunctive role in treating dissociative disorders. No medications specifically target dissociative symptoms, but various classes of psychotropic medications may help manage comorbid conditions or specific symptom clusters. Antidepressants may address depression, anxiety, or post-traumatic symptoms that frequently co-occur with dissociation. Mood stabilizers sometimes help with affective instability, while low-dose atypical antipsychotics occasionally assist with intrusive symptoms or severe anxiety that interferes with functioning. However, medication response in dissociative disorders is often unpredictable, with some individuals experiencing paradoxical reactions or different responses across identity states in DID. Benzodiazepines are generally avoided due to potential for dependence, risk of disinhibition, and tendency to interfere with trauma processing, though exceptions may exist for specific, time-limited purposes under careful monitoring. Cross-cultural perspectives on dissociative phenomena reveal both universality and diversity in manifestations across different socio-cultural contexts. Dissociative experiences appear in cultural idioms of distress worldwide, from nervios in Latin American cultures to various possession states described across African and Asian settings. Cultural factors influence not only the expression and interpretation of dissociative symptoms, but also their social meaning and consequences. In some cultural contexts, certain types of dissociative experiences may be valued as spiritual gifts or accepted as normal aspects of religious practice, while in others they may be highly stigmatized or attributed to supernatural forces. Culturally competent assessment and treatment require understanding these variations while recognizing that pathological dissociation, distinguished by distress and dysfunction, appears across cultural boundaries, suggesting underlying commonalities in human response to overwhelming experiences despite diverse cultural frameworks for understanding and expressing suffering. Dissociative disorders in children and adolescents present with some age-specific manifestations that reflect developmental differences in identity formation, memory consolidation, and emotion regulation capacities. Rather than the more distinct identity states seen in adulthood, children may show marked behavioral regressions or progresses, referring to themselves in the third person, or attributing behaviors to imaginary friends or other entities. School performance often fluctuates dramatically as different self-states with varying cognitive and emotional capacities emerge in the classroom setting. Trauma symptoms may manifest through repetitive play or drawings rather than verbal narratives. Assessment must carefully distinguish normative developmental phenomena such as imaginary companions from pathological dissociation, while treatment emphasizes developmental needs for safety, nurturing attachments, and age-appropriate autonomy alongside trauma-specific interventions. Given children's ongoing developmental trajectory, early intervention offers particular potential for preventing the consolidation of fragmented self-states into more rigid dissociative structures. The relationship between dissociation and trauma has received renewed attention through the construct of complex post-traumatic stress disorder, C-PTSD, now formally recognized in ICD-11. This condition, resulting from prolonged exposure to inescapable traumatic stressors, shares many features with dissociative disorders, including disruptions in self-organization, affect regulation, and relational functioning. Some researchers conceptualize dissociative disorders and C-PTSD as representing different points on a spectrum of adaptation to developmental trauma, with various manifestations shaped by factors including trauma timing, severity, chronicity, and individual constitutional differences. This dimensional perspective has important implications for treatment, suggesting transdiagnostic approaches that address core trauma-related difficulties while respecting diverse symptom presentations. The shared etiology and symptomatic overlap between these conditions has also stimulated research on potential neurobiological markers that might clarify boundaries between distinct but related trauma-related conditions. Societal attitudes toward dissociative disorders have fluctuated dramatically over time, reflecting broader cultural anxieties and theoretical tensions within mental health disciplines. Periods of recognition and legitimization have alternated with waves of skepticism questioning the validity of these conditions, particularly DID. These controversies partly reflect genuine scientific questions about memory processes and suggestibility, but also reveal deeper philosophical tensions regarding the nature of self, consciousness, and the impact of extreme experience on psychological functioning. The polarized discourse has sometimes overshadowed clinical realities, where individuals with dissociative symptoms continue to suffer significant distress and impairment regardless of theoretical positions on etiology. Contemporary approaches increasingly move beyond simplistic dichotomies, either valid conditions or iatrogenic fabrications, toward nuanced understanding of how biological diatheses, developmental experiences, sociocultural contexts, and therapeutic relationships interact in shaping dissociative phenomena.